Good morning, everyone. Thank you for joining us for Pediatric Grand Rounds. Thank you for joining us virtually. As always, you're welcome to join us in person at the Mill Mountain Conference Room in the Tanglewood Conference Center. Today's speaker is Dr. Hugh Kraft. So the introduction is that he's been here for a very, very long time. He is, I believe, the longest serving member of the Department of Pediatrics. He says he came here at the same time as Dr. Wilson in neurology. Everybody else has long since retired, but he celebrated 40 years last month at Carilion. So, Dr. Kraft came to us from UNC many years ago. He's worked at Carilion as a neonatologist, a pediatric intensivist, a hospitalist, and now as a general pediatrician for many, many years at the Postal Drive complex. He also is very adaptable. He now precepts the history of medicine elective for the fourth year of VTC SOM students. He's a facilitator for the ethics blocks for the first year of VTC students. He continues to serve Carilion as part of the ethics committee and consult service, and he's interested in anything outdoors. Please join me in welcoming Dr. Hugh Kraft.
Thank you. Good morning, everybody. Anything outdoors includes walking my lab every morning, and she was quite upset this morning that we could not walk before I came over here. I was thinking about this talk. I first put this talk together when I was transitioning from the NICU to the PICU. And it's changed. Some things have changed. I've added a few things, but it's interesting. I thought back at that time, we had 7 faculty members, 4 of whom were neonatologists, and 2 were generalists. And the 7th one was Bill Gay, who had just come here in cardiology. And I don't know what the faculty total is now, but I think it shows you that was about 1990, how much the department has grown and changed and evolved during that time span. And this topic has been an interest of mine for many years. It reflects not only what changed in the care of newborns, but that reflects a lot of what changed in just the care of patients in other areas. And I'll get into a little bit of that as we go through this. So, all right, this is the maternity hospital in Paris in 1880. And, you know, if you were an American physician and you wanted to be really well educated in the 19th century, you went to Europe after you went to medical school. That's where you went to do your residency or your fellowship. That's where everything was happening. It just hadn't started in the U.S. And Paris was one of the centers. Linnaeus and the stethoscope. Bichette was an early pathologist. Pierre Louis is actually a very early clinical epidemiologist. He demonstrated in about 1820 that bleeding patients actually made them die quicker. But the bleeding continued for another 50 years before it finally was discarded. So he was really an early clinical investigator. And then Claude Bernard kind of got the field of physiology started, and of course Louis Pasteur in microbiology. So there's a lot going on in France in the 19th century. And these 2 individuals were obstetricians in Paris, and the one on the left was the professor, Stéphane Tarnier, and Pierre Bourdin was his one of his pupils and became one of his residents, and eventually was his protege. And back then, there weren't any pediatricians at this time. Obstetrics was actually, there were obstetricians and there were gynecologists. It really had not come together as one field yet. And the obstetricians took care of children until they were about 2 years old. So they would deliver the child and take care of the child, and then at 2, they would kind of be farmed out to the general practitioners or the apothecaries or whoever was doing, general care in the community. But what Tarnier was really known for is he came up with the first design for what became the modern incubator. And it said he got the idea, he was at an agricultural exposition and he saw some incubators for chicks. And he kind of said, well, yeah, we could do something like this for infants, because keeping them warm was so important. And there have been earlier models, earlier ideas about incubators, but this is really the first, what would become the modern incubator. And the little pyramidal objects underneath the baby, they're hot water bottles, and they would change those out periodically. And so air circulated around the hot water bottles and around the baby. And so this was really the first modern incubator. And they began to manufacture these and use these in what was really the first neonatal intensive care unit, which was in Paris. And I'll show you some of the numbers of things that they reported with using this. His pupil, Pierre Bourdin, was born on a farm, humble family, didn't manage to go to college and medical school. Wrote a thesis on cephalopelvic disproportion, and he studied under Tarnier at the maternity hospital in Paris. He also studied under Lister in Edinburgh, and he succeeded Tarnier when he retired in 1895. And he's known for a number of things. He designed what was really one of the first gavage feeding tubes. How do you feed a baby who's born early and can't suck and really swallow? So that what you see on the left is an image of a gavage feeding tube that he designed and used in his nursery. And the other image doesn't really show up. I wish the detail was a little better, but that's really the first modern neonatal intensive care unit. And the large space is for well babies. The rooms on the bottom were isolation rooms, and the second floor was the dormitory for the wet nurses. So instead of breast milk banking, they actually had women who were nursing their own infants and also providing breast milk for the premature infants. So that's really the first neonatal intensive care, and they reported some really interesting statistics. The graph on this side shows this is mortality by birth weight and initial temperature. So under 32 degrees, this is less than 1,500 grams. Mortality was almost 100%. If their initial temperature was very low, a little bit better, not much. If you're between 1,500 and 2,000, but significantly better if you were over 2,000. And then the babies whose initial temperature was higher, you can see mortality is a little bit better in the smallest, better in the kind of in between the 15 to 2,000, and improved in the larger babies as well. And this slide shows, I had to look at this for a while to kind of figure out exactly what it was showing, but basically the blue bar are all outborns that were brought to the nursery. The red bars those were babies born at the hospital where the nursery was. So these are outborns, inborns. And this shows you that, this is outborn mortality. If they're chilled, very high, a little bit better if they're warmer. And it's basically the same because these babies were born where the nursery was. So even if they were a little cool, being born at the hospital where the NICU was, getting warmed up quickly didn't really cause any difference in survival. And actually, I got these images. There's an original copy of this is from Boudin's textbook. There's an original copy of this in the library at UVA that I had a chance to look at. So these are actual images from his book, which I'll talk a little bit more about in a few minutes. And then these graphs should look familiar to anybody who's worked in the nursery. The red lines are weight gain. That looks pretty familiar. This baby was about 1,200 grams. This baby was close to 1,300 grams, and then the blue bars are milk intake. And they look much different from what you see in the NICU now. And there are a lot of graphs like these in his textbook. They're really fascinating to look at and kind of contemplate, what they were thinking about and doing. And then they published their results. Mortality, infants less than 2 kilos. It was the Department for Weaklings. Before they started using incubators, mortality was about 66% for that entire group. And then when they started using incubators, mortality dropped significantly. So just keeping the babies warmer had a huge provided a huge difference in survival. And then Boudin went on to write what really is the first textbook of neonatology. And you can actually get their reprints of this. And it's really fascinating to kind of read, the words of the doctor, who was really kind of the first modern neonatologist in terms of thinking about what things were important in improving survival of small and premature infants. And this is from his introduction. Infants enfeebled by birth should be guarded with special solicitude. Not only do they share to a greater extent than full-term children the ordinary risks of infancy, they labor under a danger which in its intensity is almost peculiar to them. I refer to the great readiness with which they become fatally chilled. With weaklings, we have to consider 3 points. And these are the 3 things he talks about in his book. The importance of temperature, the importance of nutrition, and then the particular clinical things that premature infants were susceptible to, particularly respiratory issues. And his approach to care in the nursery was, it sounds very similar to what we do now. The healthy babies were cared for in one place. The sick babies were isolated, or if there was concern, they might be. It's interesting, they kept the wet nurses' babies away from the prematures, again, trying to reduce the risk of infection. They had a special room for preparing and storing breast milk. You can see a lot of things here that, kind of resonate with what we do today, particularly as related to preventing infection in the nursery. And his key contributions were the recognition of the importance of maintaining normal body temperature, provision of adequate nutrition with breast milk. And, this was 125 years ago. When I was doing my fellowship, breast milk was just starting, Dr. Hart can probably remember this too, just starting to kind of work its way back into the NICU. For up until that time, it had really been special formulas. And that's probably a separate grand rounds, just going through, why did it go in that direction? Keeping mothers and infants together, and they followed these infants, they followed their graduates for a couple of years. So they had a follow-up clinic. So again, this is very similar to what we do with these patients today. Move on now to talk about a really interesting individual. Martin Cooney there's a lot that's not known about him, but it is known that he studied in Paris with Boudin, and he also got to know an inventor in Germany, Alexander Lyon, and Lyon had kind of he designed kind of the second generation incubator. And, this was all new technology, and it was first demonstrated and used. There used to be these world expositions and world's fairs and things like that, and all the new technology would be shown at those kinds of events. Well, incubators began to be shown at these events, and so that first in Europe, and then eventually in the United States. And so the first NICUs, if you want to call them that, were really these infant incubator pavilions that were at the Buffalo World's Fair or the Chicago Exposition, or there was a big one in Omaha, and babies would be born at home and taken and rushed out to the incubator pavilion. I mean, that's how. Which, we look back on that and go, but we know that's just the way it was. Most births then were at home, and if somebody a baby was born and was born early, and the neighbor knew, well, they've got this pavilion now, down at the fair, they would rush the baby out there. So anyway, it's kind of fascinating how NICUs first started. I love it says with living infants. And the image on the left, that's from Buffalo at late 1900s. And that the image on the right is the inside. And so you would pay your whatever, and you would walk around, and the incubators all had attendants, and those were the Lyon, the kind of the second generation incubators that were being shown. And it's interesting, Cooney went on to set up his own kind of NICU out at Coney Island, which he ran for 40 years. Babies would come out there and be taken care of. And when they were ready to go home, they would get a little diploma. And that's a picture of some of the nurses who worked in these early neonatal intensive care settings. It's really a fascinating story when you think about it. Moving on just a little bit, I want to talk about Julius Hess. He was a native of Chicago and studied pediatrics at Hopkins. And he actually had a horse and buggy practice in Chicago for a while, and then he actually went to Paris and had some exposure to neonatal care in Paris. And we think, although it's not entirely clear, he may have met Martin Cooney in Paris, but they somehow became connected and friends, and Hess really became aware and interested in what Cooney was doing to care for prematures. And so he actually set up the first, it was called the Premature Infant Station, the first NICU in the United States at a hospital. That was at the Sarah Morris Hospital in Chicago in 1922. And he designed an incubator that's a little bit different. You might know what that thing is sitting to the left of the incubator in this picture right here. What's that tank? That's an oxygen tank, and I'll come back to that. Because the cyanotic episodes, blue episodes were recognized, and oxygen was becoming available for clinical use. And so he adapted his incubators to be able to be connected to oxygen tanks. And he emphasized the things that he had learned in Paris, and he cared for over 9,000 premature babies over his 30-year career. Quite remarkable. He wrote the first U.S. text on the care of the premature infant. And he also designed the first infant transport incubator. So if a baby was born somewhere, they would send an ambulance out in the transport incubator out, bring the baby back.
Do you know what the youngest gestational age that he was successful with was?
Not sure. So he's kind of considered, there were other doctors, there was a physician at Harvard who was doing some work with preemies, but Hess is really considered kind of the first modern U.S. neonatologist who really devoted his entire career to that. And then he published the first very detailed and long-term follow-up study of his experience in 1953. And you can see those are his survival numbers, lower at the very low birth weights, but 91% survival between 2 kilos and 2,500 grams. Now, and I put this in because this will tie into someone else I'm going to talk to. The Children's Bureau was created in the early 1900s, and it reflected there was increasing interest in our country in children's health and in doing things to improve children's health. And so this was a federal agency created to focus on child health and welfare, kind of a small first-year budget. I'm not sure what that is in $2,025, but it would evolve into the Office for Child Development in the Department of Health and Human Services. And I put this in here because Julia Lanther, who was the first head of the Children's Bureau, she was the first woman to head any kind of federal agency in the United States. And then these two women are really interesting. I'm not going to talk about Martha May Elliott. She and Ethel Dunham, I think they were classmates at Hopkins in medical school. And Martha May Elliott went on to have a very distinguished career in public health. Get a chance to read a little bit about her. Dunham, after medical school, went to Yale, and she was the first female house officer at New Haven Hospital. And she focused, her real interest was newborn care and follow-up. First woman appointed professor of pediatrics at Yale, and she was appointed chief of child development at the Children's Bureau in 1935. And the reason I brought her in is that she put together and published standards and recommendations for hospital care of newborn infants. And this really was the boilerplate for what became the guidelines for perinatal care that the American Academy of Pediatrics subsequently published. So her work really was the first version of the guidelines for perinatal care, which the AAP revises every 3 to 5 years now. It's been I think it's been continuous publication since the 50s. But that was one real contribution that she made, was she wrote all that, she put all this stuff down first, and the AAP took it and kind of modified it, adapted it, updated it, and today it's what we use as the guidelines for perinatal care. Now, I want to get to a little bit of clinical care. There are no hematologists in the crowd, are there? Good. Okay. These cells that have dark nuclei are not blasts. You've got low power on the left, high power on the right, and you see lots of them. And the higher power on the right, anybody want to comment on what the red cells look like? They look kind of shaggy and like they've been, something's been taking bites out of them. You really don't see nice round red blood cells. And those nucleated cells that you see in the left image, those are all nucleated red blood cells. So this is a blood smear from an infant with severe anemia. And what would be 50, 60 years ago, what would have been the most common cause of severe anemia at birth in a newborn? Or RH incompatibility. So this is a blood smear from an infant with RH incompatibility, and the red cells look like they do because they go through the spleen, and the spleen plucks off that antibody that's on the red cell, but it takes on the red cell membrane off with it. So the red cells look kind of like they've been chewed on. And RH disease, this was an incredible clinical problem. 40s, 50s, 60s. This is pre-Rogam. We don't even think about it anymore. But people working in the NICU or taking care of newborns at this time, that they would see severe RH disease routinely. It would have been a very common problem in the neonatal unit. And the image on the left is a baby who's kind of got full-blown fetal hydrops. And so the mom makes antibodies across the placenta, and then the fetal red cells are just kind of continuously destroyed. The fetal bone marrow can't keep up with it, and so you end up with a baby that's hyperproteinemic and has ascites, edema, really quite very ill at birth. I saw a couple of these in fellowship. I don't know if Dr. Herman saw one or not. By about 19...
Not quite this bad with RH eye drops.
by about the early 80s, this had vanished. It had really vanished. So that's what severe RH disease looked like. And another part of the RH issue was these babies were severely jaundiced as well because of the increased red cell destruction. And severe hyperbilirubinemia, which fortunately we don't see with really any frequency now, had a whole list of severe complications. And the physicians that began to address this, it's interesting, the first report of the umbilical vein being used for a transfusion was by Dr. James Sidbury. His son went on to be a faculty member at Duke, but he was working at a small hospital in Wilmington, North Carolina, and wrote the first report of using the umbilical vein to transfuse a baby. That was probably 1923, 24, 100 years ago. And it didn't really go anywhere, and it was published in kind of an obscure journal, so that might be one reason why. But the first exchange transfusion was done by Louis Diamond at Boston Children's, and he was really an early pediatric hematologist. Diamond, black fan anemia, he was one of the early pioneers. And he was able to show that survival with RH disease pre-exchange, it was 10%, 70% post doing exchange transfusions. So exchange transfusions had an incredible impact on survival in infants that had severe RH disease. And I want to move on now and talk about respiratory issues, which, as we all know, is a common problem in premature infants. I showed you the image of Dr. Hess's incubator with his oxygen tank, and gradually physicians caring for newborns started to use oxygen routinely, and they basically would just kind of run the hose into the incubator and turn it on, and the baby was pink, maybe they turn it down a little bit. This was before analyzers or blood gases like transcutaneous and pulse oximetry was like 60 years down the road. So it was really primitive by current standards. Gradually the incubators got to be better. And they became more airtight, and so less leaky, so the oxygen content in the incubators was going up, what the babies were breathing. And then In February 1941, a pediatrician in Boston made a routine home visit to see a 3-month-old who had been born a couple of months early. And he wrote in his little diary, he wrote in the baby's chart, although the baby's general development was excellent, I was shocked to see roving nystagmus and opacities in the eyes. I had to tell the family I was afraid the baby could not see. And so he got an ophthalmologist to examine this baby. Actually, I'm a little ahead of myself. A week later, he got another call. And so he went out to see a second baby. And this baby's eyes appeared exactly like the first baby's. It's interesting, this infant was a surviving twin and had birth weight of just over 1 kilo, which, I mean, back then would have been probably a very SGA twin. You'd have to assume to survive at that birth weight. But he got the ophthalmologist involved, and Theodore Terry was a well-known ophthalmologist at Massachusetts Eye and Ear Infirmary, and he examined the second of these 2 infants, and after encountering 3 other cases, he wrote, in view of these findings, in 5 infants born prematurely, perhaps this complication should be expected in a certain percentage of premature infants. If so, some new factor has arisen in extreme prematurity to produce such a condition, because it really had not been seen before. And so this opened up this entire kind of area of uncertainty. What was changed that was causing blindness in premature infants? Harry Messenger was a neonatal ophthalmologist. He coined the term retrolental fibroplasia, which has been replaced by retinopathy of prematurity. And Terry went on to collect, over the next 3 years, over 100 cases of babies with the same thing. And all of these had blinding RLF, not just, stage 1 or stage 2. And there was about a decade when the nursery docs and ophthalmologists really could not figure out what was going on. There were a lot of new therapies that had been introduced. Feedings had changed. Vitamins were being given. There was oxygen. Some nurseries had high prevalences of it. Other nurseries had lower prevalences of it. But it really wasn't clear what the cause was. And that was the state of things for about a decade. And then it wasn't just the United States. This is Victoria Cross. She was like the Julius Hess of England. She was a very early pediatrician who took a special interest in newborns. And she reported that 10% of her premature infants had developed blinding, scarring, RLF, but during the preceding 16 years, they'd had no cases of it. And in 1948, their nursery had acquired 2 modern American incubators, which were much more airtight than the British incubators they were using. So that was one thing that had changed. So that was a hint that maybe oxygen was playing a role. And then finally, there was a multi-center trial done in the U.S., 1953, 18 hospitals, and infants were assigned to receive routine oxygen, which is just, they just turn the oxygen on and kind of, baby looks good, we'll turn it down a little bit. Baby doesn't look that good, we'll turn it up a little bit. Or to be more careful and curtailed oxygen was really limiting in most cases to 40% or less. If they had a cyanotic episode, they turn it up a little bit. But basically keeping oxygen, inspired oxygen content to around 40% or less. And you can see there's a marked difference. The routine oxygen had a 72% incidence of retinopathy, a quarter was scarring, 22% mortality. The curtailed oxygen, less than half the incidence of ROP, even lower incidence of scarring, and no difference in mortality. And then this was a study that finally pinned down oxygen as the culprit. And at this point, the technology was finally coming around that oxygen content in the incubator could be measured. Blood gases were still not quite available, but at least at this point, the oxygen content in the babies were breathing could be monitored. So oxygen began to be used a little less liberally. Famous musician who has ROP, blind from ROP. Stevie Wonder. Okay, so that's oxygen and ROP. It's a fascinating story. William Silverman, who was a well-known neonatologist for a long, long time, he wrote a book called Retinopathy of Prematurity, a Modern Parable. It's hard to find, but it's absolutely fascinating historical account of ROP and kind of, how medicine, why it took doctors so long to figure out what was going on. Who was the first woman to enter the new field of anesthesia? Some of the residents were here on Tuesday, and I talked a little bit about her, so y'all have to be quiet until other people get a chance. She made and played her own violins. She retired from clinical medicine and went to Hopkins and got an MPH, and actually became the scientific director at the March of Dimes after her MPH. She got her pilot's license and actually flew under the Brooklyn Bridge. And she created a scoring system to assess the adaptation of the newborn to the outside world. This is Virginia Apgar. To say she was remarkable is a modest understatement. But that's her original paper that reported her score, published in 1953. And someone was able to kind of make a mnemonic out of it. And the legend is that she was in the hospital cafeteria and with some students and residents, and they were asking her about, what's your method for assessing a newborn after birth? And she wrote it out on a hospital napkin, but apparently the napkin is lost to history. That'd be an interesting napkin to have. But you think about her score, we're still using it, 75 years after she came up with it. And she was just a remarkable woman. One of many that are kind of, as we go through this, we'll see a few more. Rochford Hospital in Essex, England, 1956. The sister in charge of the premature babies unit had early reported the apparent fading of the yellow pigmentation of the skin of jaundiced babies when they had been for a short time in sunlight. This was the first hint that light would impact bilirubin. And so the physicians did a study, and this is the first paper that shows that light does in fact reduce jaundice. The image on the left is exposure to sunshine and then taking them back away out of sunshine and then putting them back in sunshine. And you can clearly see when they get some sunlight, their bilirubin comes down. And then they use artificial light and demonstrated the same thing. And I don't know the nurse's name, but they did thank her in the very small print at the end of the article, which was maybe not the most appropriate thing to do, because she was the one who really made the seminal observation. The a lot going on in the 50s in neonatology. If you want to get into the history, that was kind of the decade. There was a lot going on. There was a lot of use of prophylactic antibiotics to prevent infection. And, I don't really know if infections were more common. I don't really have a good feel for that. It may have been because more babies were outborn coming in from home. That could have been an issue, but then there were new antibiotics available. And this paper looked at difference in mortality between premature infants allotted to 2 different antibiotic regimens. And this was done by William Silverman, who kind of was the first neonatologist to actually use clinical trials, randomized clinical trials, to try and sort out, do things work or do things cause harm? And so they randomized 193 babies to 2 antibiotic regimens. One was tetracycline, which, we think about tetracycline for newborns. Well, that's kind of the way it was back then. Or penicillin and a sulfa. And the outcome measures were mortality under 5 days and after 5 days. And so these are the results. Tetracycline group, deaths under 5 days, 20. In the pen-sulfa group, 46. Autopsies were actually, there were a greater percentage of infants autopsied in the tetracycline group. But the key finding here was there was 1 case of kernicterus in the tetracycline group, and there were 12 cases of kernicterus in the sulfa group. And so this was the paper that it kind of ignited the question, are some of these medicines we're starting to use having adverse side effects? And then this is the same study, but looking at age 5 days and over, and it basically shows the same results. More deaths in the pen-sulfa group and no kernicterus in the tetracycline group, 7 in the pen-sulfa group. And this study raised a lot of concerns about all these new things that were just being tried. I mean, there were all sorts of new therapies coming out, particularly for newborns, and then people were just trying them to see if they would work, and not being used in a controlled fashion, studied in a controlled fashion. All right, this is interesting. When did the lights come on in the U.S.? That quote was by a famous neonatologist. He was the chief of neonatology at the University of Vermont, and he was the editor of Pediatrics for about 25 years, and that's Jerry Lucy. He wasn't that impressed with the original article that I just showed you, and in 1965, a pediatrician came from Santiago to be a fellow with him. And after being quiet and rounding for a couple of weeks, he asked Dr. Lucy, he said, "Why are y'all using phototherapy?" And Dr. Lucy said, "Is anyone using it?" And he said, we've been using it in Santiago and it seems to work. So he said, "Well, go to the library and find some papers." So he went to the library. And he found over 20 articles, but none of them were in English, that showed that phototherapy definitely worked. And Dr. Lucy was appropriately humbled and said he was going to have to start keeping up with the international literature. And they did a clinical trial in their nursery and showed that phototherapy clearly leads to lower bilirubin level. So that's how the lights came on in the United States. And these 2 slides, the bars are kind of incidence of exchange transfusion, and the data is each bar is a study from one's from Australia, one's from Greece, I think one's from the U.S. The one on the left is all birth weights. The one on the right is under 1,500 grams, but you can see that by the late 1990s, that no exchange transfusions were being done. So really the combination of ROGAM and phototherapy, exchange transfusions have just vanished. When was the last time y'all did one in Charlotte before?
I've only done one in my career.
Yeah. Preston Bogus, who was a faculty member here for many years, he was one of the first neonatal fellows at Duke with George Brumley. And he did 99 exchange transfusions his first year of fellowship. He said he wanted that 100th, but it's just hard to fathom doing 99 exchange transfusions. Anyway, so that's where ROGAM, phototherapy, that the procedure has vanished, and they were time-consuming, expensive, hazardous. It's good that we don't have to do. All right, let's move on and talk about respiratory issues. RDS, hyaline membrane disease, it was called atelectasis neonatorum in its early days. And the pink, the little arrow with the pink stuff, those are the hyaline membranes in the alveoli. There was increasing interest of this in the 1950s. And Mary Ellen Avery was, I think she was a fellow at Harvard at the time, and there was I think Dr. Mead, Jerry Mead. They looked at pulmonary extracts and measured surface tension in infants who died from RDS and from infants who died from other things. And you can see the surface tension measurements in black much higher than the ones in the open circles. And those are the infants that died of hyaline membrane disease, RDS. So this was the study that demonstrated there was something in the alveoli that was keeping them open. And that eventually was determined to be surfactant. Well, what's fascinating about this is there were some early surfactant trials in the early 60s, but it was literally 30 years after this before surfactant was developed in a form that could be used clinically. It literally took 30 years. So, but I've wondered about this. I've wondered if assisted ventilation became much more available and effective, and I almost wonder if that delayed surfactant research some, because ventilators seem to be saving a lot of infants, and perhaps that was a part of this. Is an early image of a negative pressure ventilator, and then there were all sorts of ventilators early on. What really got research going in this area was John F. Kennedy's wife, Jackie, had a preemie, 34 weeks, kind of a big preemie, but severe RDS, and actually taken to Boston and eventually died from RDS at 34 weeks gestation. This is interesting because we have a connection here. Leon Arp was a professor of biomedical engineering at Virginia Tech for many years. Dr. Althouse.
I took his class at Journal of Biomedical Engineering in 1978.
And Andy Mulliner, who was the first pediatric pulmonologist here, was one of his graduate students. He developed an early infant ventilator and treated over 100 infants at Roanoke Memorial with that ventilator with very good survival rates. Published 2 papers, but he didn't get together with a company to commercialize it. And he developed one of the first sensors that could sense an infant breath, and the ventilator would then deliver a breath. And so that the early treatment of RDS, early ventilation, one of the earliest places was actually Roanoke Memorial Hospital. And his was spurred on by, he had had twins who both had RDS and survived, but that kind of inspired him to get into this area. And I think the woman in the picture is a nurse, but was actually one of his first patients. So that's him with one of his ventilators and one of his first patients. And then with more and more widespread use of ventilation, a new disease appeared, and it's what we now call bronchopulmonary dysplasia. And it was basically barotrauma and oxygen, and ventilators were not as precise, and not like they are now. And it was basically just lung disease from pulmonary injury related to oxygen and barotrauma. Now it's more related to infants of very low gestation whose lungs are just very, very premature at birth. And then this, to kind of wrap things up, there was a lot of controversy about when do we feed babies. Delayed feedings was kind of the practice for many years for prematures. And then finally, a couple of neonatologists in England said, well, maybe this isn't a great idea. So they studied a population between 1 and 2 kilos, started feeds at 2 to 3 hours, continued every 3 hours. And they used some controls. There were other hospitals that wouldn't buy into doing some babies this way and some babies another way. So they used controls at another hospital where they were just doing the routine later feedings. But what they were able to demonstrate is that feeding early was safe. You got back to birth weight faster, you passed meconium sooner, and you had less jaundice. So this was the study that really got feedings for prematures moving in the direction of starting early. And then to wrap up, most of the changes since I've trained and have just been improvements in things. We can analyze little samples of blood. We've got small ET tubes, small catheters, better ventilators, imaging technology, significant advances in surgery and anesthesia, and now we've got non-invasive monitoring. All this is just the result of kind of continuous improvement in how care began. And a better understanding of the importance of gestational age and birth weight. NICU's now a little gentler, a little quieter. Nutrition has improved. Maternal fetal medicine advances there, so we know about problems ahead of time. This is a true story. The first C-section I went to here, it was a mom, 34 weeks, placenta previa. The mom had not had an ultrasound. That actually was possible back then. You could have a baby and never have had an ultrasound. Anyway, it was conjoined twins. So that was the first C-section I went to. And I came back to the nursery and I said, I've come to the right place. This is going to be good here. When we called in and told them we had conjoined twins, my partner said, no, he's just kidding. He didn't. Anyway, nurseries are quieter, air is regionalized, transport's much better. More ethical issues with small babies and babies that have suffered, severe intracranial hemorrhage, asphyxia, things like that. But overall outcomes have really improved. And we owe a lot to Professor Boudin because we basically have taken his 3 areas that he felt were critical and expanded those, and they really remain the key principles that we use to care for babies in the nursery today. And I love showing this picture. This is my better half. And That's the first time she held our son, who was born a year before surfactant was available. And ended up was on the ventilator for about a week. And so this is her first chance to hold him after being extubated. Get some good readings on this if you want to get more into it. It's a fascinating area. I've got the questions. I know y'all need mock questions. Here we're going to emphasize all of the following in caring for weaklings, except
D.
The use of oxygen.
part of D. Would everybody vote for D? Yeah, oxygen hadn't quite come around yet. Which of the following contributed to the epidemic of RLF in the 1940s?
C.
Liberal use of oxygen.
Actually,
Increasingly less.
I think A is the answer because they were using the same amount of oxygen, but the incubators weren't leaking as
Wouldn't
much.
it be more airtight?
Airtight.
Because it says increasingly less airtight, so if it was more airtight, then that makes sense. But
But they're more airtight, then less of the oxygen's leaking out, so the baby's breathing a higher concentration.
Bill, you're correct.
And which of the following is a true statement about bilirubin and phototherapy? Yeah. And you know that she noted that, or she told one of the doctors, she said that in their nursery they had incubators on the wall and incubators that by the window. And she told one of the doctors, she said, you know, the babies by the window always seem less yellow. And that's how that observation came to be. But anyway, that's kind of a very quick tour of kind of where neonatology started, how it's developed, and I hope it was interesting. And if there are any questions, I'll take those now.
Not a question, but kind of a comment. It was a fantastic talk, very elegant, and you're absolutely right. All these things kind of came on one at a time, and I trained right after surfactant came through. And that was revolutionary. And then the next thing that's been revolutionary has been cooling for asphyxiated babies. Yeah. So that's the next one that came through. So, and you're right, the ethical issues continue because as we get better and refine all the things that we do, we're pushing that gestational age down to 22 weeks. And at some point, we're going to get a point. There is a point where it's not, where there's diminishing returns.
Yeah, I did get into the baby doe and all that kind of, that's almost a whole separate talk.
And I always thought that the Patrick Bouvier Kennedy story would be a great movie, a great biopic.
Yeah. Well, apparently when they transferred the baby to Boston, every well-known neonatologist in the country went to Boston.
But they didn't want Mary Avery to take care of the baby, but she was the expert in RDS.
Yeah.
Because she was a woman.
Millie Stallman was one of the ones who went from Vanderbilt up to Boston to help out. Yeah. Okay, well, thank y'all.